Hello, dear students. Today we are having a lecture dedicated to epidemiological research methods in healthcare and fundamentals of clinical epidemiology and evidence-based medicine. My name is Viktor Semenov. I'm going to be your lecturer today. Let's begin with the definition. Epidemiology is a discipline which explores the causality of diseases. This is just the very basic definition of epidemiology, but it doesn't limit all the tasks that epidemiology covers. Epidemiology also is the study which investigates the determinants, occurrence, and distribution of health and disease in a defined population. So not only diseases, but also health. Actually, what matters with health or the problems with health will be a question of epidemiology on different scales. Epidemiology is the basic science of public health. So in a way, you can consider epidemiology as a subdivision of a public health science. It provides, as I've said earlier, the insight about causes, nature, and spread of diseases. It studies the natural history of disease and its evolution and tries to foresee how the disease will develop both in an individual and in a population. Epidemiology defines the preventive and treatment strategies for different diseases. And also it creates the framework or environment for making decisions which would be based on the existing or accumulated body of evidence. Epidemiology is, first of all, as a quantitative field. So it means that whenever possible, epidemiology operates with numbers and tries to justify the decisions made within this field by calculations. So here on the screen, you can see the basic list of what can be within the operation of epidemiology. Those are measures of frequency, such as counts and proportions. Those are measures of associations like risk ratio, odds ratio, regression coefficient, etc. Those are the values of statistical inference like p-values or confidence intervals. And for example, the parameters of disease burden like incidence or prevalence. We are going to cover some of these parameters in a bit more detail within the scope of the lecture. When we are working in an epidemiology, we are operating with hypotheses. So these hypotheses or ideas or educated guesses that need some proof or disproof. So hypothesis is an educated guess. Yes, so we have some basic knowledge behind our idea. For example, we suggest that water can be the medium which through which some pathogens can transmit from one people to another one. This idea doesn't get out of nowhere. This idea should be preceded by some observations. For example, that people that drink water from one source would fall ill, and people who drink water from another source would not fall ill. And this creates the idea that maybe the reason is in a source of water being used by different people. This is why some of them fall ill, some of them do not fall ill. So this is an educated guess, but which is not proven yet. And via experiments, via some reasoning, this idea can be proven or disproven. And ideally, this proof of this idea should be confirmed or supported by numbers. And this is where epidemiology steps in. So epidemiology offers the set of methods which allow us to prove or disprove some hypothesis with a certain probability of success or certain probability of error. This is roughly the same, but describes the situation from different sides. When we speak about types of studies which are used in epidemiology, we need to divide them, first of all, into two main groups. First of all, they are observational, and another group is experimental. Observational studies are further divided into descriptive studies and analytical studies. Experimental studies include randomized controlled trials, field trials, and community trials. So, observational studies. Observational studies, which go from their name, deal with the observation of some phenomena. So it means that there is no manipulation with the study object. The study subject, in other words, the observer or scientist, just makes some records about the nature of the study subject and maybe makes some inferences about what the scientist sees. Observational studies are divided into descriptive, which limit themselves only to a description of a subject. For example, studying of natural history of a disease. It happens when, for example, we know very little about disease, and the first task is to describe what we have on hands. We had an information with which to work further during analytical and experimental studies. Next, more advanced stage are analytical studies, which together with description of the studied phenomenon aims to provide an explanation to what experimentator or scientist sees. For example, it might be analysis of influence of exposures on the disease development, but it's very important without influencing studied populations. Yeah, so for example, if we would like to extend the example with studying natural history of a disease, we can say that it's not only studying the natural history of one disease, but it may, for example, maybe serving different people with the same disease, but with recording which exposures these people have. Some of people may, for example, have influence of smoking. Some people may have influence of some factors which occur on their workplace, etc., etc. So descriptive studies used when very little is known about a disease tries to answer questions which can be grouped as what, when, and where, and may, as the top point, suggest some associations, so drive some hypothesis which should be proved or disproven, proven or disproven in further studies. In turn, analytical studies used when some insights are available, usually from descriptive studies, try to answer the question why already. And also the analytical studies try to draw conclusions about causality of diseases. Yeah, so these are more advanced studies with more in-depth analysis. But still, I would like to emphasize that both these types of studies are observational, which do not imply any manipulation with the study participants or the phenomenon which is being investigated. So we would like to dig a bit into analytical studies. So analytical studies can be divided by timing into a group of cross-sectional studies and longitudinal studies. Cross-sectional studies are the studies which assess the information in a certain time point. So this might be, for example, one time point roughly. So, for example, the investigations which were conducted in the same day. Yeah, so it will be a cross-sectional study. So some measurements which were done in one calendar day or in 1 month, so it will be one time point. But it not always should be restricted to one day, to one time point for all study participants, because, for example, it might be one time point in a different way. For example, it might be the first day of the disease, or the day of first manifestations, or the day when the diagnosis of a disease was established. Yes, so it will be a different day in calendar for different study participants if we're speaking about patients, but it will be still the first day of disease, first day of manifestations, first day of diagnosis. So it will be a cross-sectional analysis in which we register the phenomena which occur in one certain time point without any observation of what has happened next or what had happened before. By contrary, there is another group of studies, which is called longitudinal studies, which are divided into prospective and retrospective ones. Prospective are the studies which imply observation of study participants or studied phenomena further over time. And retrospective studies are the studies which imply the observation or investigation of the study participants or studied phenomena backwards in the time using some records. Let's discuss the example of prospective or retrospective studies using the examples. So prospective studies are when individuals are followed over time and data about them is collected during the conduction of the study. The classical example of prospective longitudinal study is a cohort study. Cohort study is very well understandable and pretty kind of simple kind of study, in a way simple, because what it does, it takes from general population some pool of participants to form event-free example. So we set an event-free example in order to proceed with them in the study further. Then this example is divided into exposed cohort and unexposed cohort. So in this, usually we're operating with terms of exposure and outcome. So outcome is a disease or result. If I'm speaking about biomedical studies, we frequently speak about disease. Yes, so disease will be an outcome and exposure will be some influence which can either increase the probability of a disease or decrease the probability of the disease. It may be as a treatment, which will prevent some number of cases, or it might be some influence like smoking or alcohol consumption, which would increase the probability of an outcome. So we just divide these people into two groups, from which one is exposed and another one is unexposed, and then we observe them over some period of time, which is usually a pretty long period of time, and we register how many people would develop outcomes in both groups. So to do it more, less theoretical, let's say that we are wondering if smoking influences the probability of cancer development. For this purpose, we set people, first of all, who do not have lung cancer. Yeah, so we will have the event-free sample so that we could compare the outcomes, the rate of outcomes in both groups. Then people decide by themselves. Either they would like to smoke or they would like not to smoke. So we do not interfere, we just register who is going to smoke and who is not going to smoke. And then we observe them for decades and calculate how many people in both groups would develop cancer and how many people would not develop cancer. So in this process, we register not only the number, but also the time period which it takes from the beginning of observation or from the beginning of the exposure till the development of an outcome. So, and in this case, for example, we will calculate the risk of cancer. Yes, so for example, let's say in this group, there were 100 people, 10 of them developed cancer. The risk will be 10 over 100, 10% risk of lung cancer among smokers. Now, let's say that there were 2 people amongst 100 in the group of non-smokers. 2 over 100 will give us 2% of non-smokers will develop cancer. It is an hypothetical example. It's not the study that I'm citing or referring. It's just a hypothetical study. And if the numbers were like I've told you, then in this case, we'll see that the risk of lung cancer among smokers is 5 times higher than among non-smokers, because in this group it was 10, in this group it was 2. Okay. The classical example of cohort study, which you might have heard, I'm pretty sure that you might have heard about it, is a Framingham heart study, which was conducted and which is being conducted, actually. It is continued in the USA. in which people were selected which didn't have any cardiovascular event, and they were followed, and some parameters in this population was measured. Yeah, and this study is being conducted for maybe a century already, maybe a bit less, but roughly it is a century. A different certain number of generations has changed in this cohort. But this study gives us invaluable information about who is at risk of development of cardiovascular complications. And these risk charts are being used very widely. For example, European adaptation is score chart used the same principle, but the numbers might be slightly different. But the approach, which was developed by a Framingham Heart Study, is pretty same. It's very interesting. I highly recommend you to read more about this study, especially if you're going to be working in internal medicine. You will inevitably deal with this risk chart. So we proceed with longitudinal studies. The next one is, one moment, please. So let's proceed with the longitudinal studies. The next one is retrospective studies, is when individuals are sampled and information is collected about their past. One of the classical examples is a case control study. So in this case, what happens? The scheme looks pretty similar, but it is principally different. So we also here have some point with general population. We have cases and controls, like cases and in this case controls, unlike previously in cohort studies, but also we have here similarly exposed and unexposed people. So what happens here? Unlike cohort studies, when we selected people, study participants, for example, and then follow them over time, in case control studies, we do not follow people over time, but we select cases. For example, if we go if we continue with the example with the cancer, we select people with cancer, which already at the moment of beginning of study have cancer. Yeah, so then we select, usually it is just random selection, some number of people without cancer, and then we check our hypothesis. So let's say that we don't know if smoking increases the risk of lung cancer, and we would like to clarify this using the design of a case control study. For this purpose, we will select patients with cancer, randomly select some number of patients without cancer, and then we will check using the medical records or interviewing patients, how many of them did have exposure, in this case smoking, and how many of them didn't have this exposure of interest. In this case, how many of them were not smoking. Yeah. Despite there is some similarity between cohort study and case control study logics, the difference is huge. It is in its reliability, and it lies in the resources which are needed for conduction of the study. So remember that in case of our study, we had to observe, to follow patients for decades, to wait until the outcome of interest will occur. This imposes a huge load for investigators, because it requires a lot of time, it requires a lot of resource to track people who might be migrating, who might be might have different willingness to participate in the study in different time points. So people kind of might be sometimes tricky to work with, yeah, especially during the prolonged time span. But this problem is solved with the case control studies, but at cost of study reliability. So we don't have to follow people for decades. We already have these decades which are reflected in their records, medical records. Yeah. So this in this case, it is simpler but less reliable design of a study. But still, kind of case control studies are very good when you have a limited resources, and you have pretty well justified hypothesis, and you have good sources of information about past of the study participant. In this case, case control study might be very useful. Just for now, I will mention it and we will discuss it further during practical lessons. In this case, we do not calculate risk, yeah? So we calculate odds. So if in case of core study, we calculate risk. So let's say that there were group of people, 100 people, among 10 of which had cancer. For example, there were, I don't know, 100 smokers, and 10 of them had cancer. In this case, we will not calculate risk of cancer for smokers, but we'll calculate the odds of having cancer among smokers. And these numbers would be usually pretty close one to another, but they have different method of calculation, and they have a bit different statistical meaning behind these numbers. Just for this, I will stop at this point for this. Also, when we're speaking about epidemiology, you need to know the parameters which describe the disease load. So usually the most popular numbers, popular indicators which are used to describe the disease load are morbidity and incidence or mortality. So morbidity is the number which describes the presence of existing cases in the population. So it doesn't matter how long these cases exist in the population. It matters that they exist at a certain period of time, for example, in a given year. So how many people are there in the population with a given disease in a given year? So this will be a morbidity or prevalence. In other words, it will be prevalence or burden of the disease. And by contrary, there is another indicator which is called incidence or mortality. Mortality is basically incidence of death in the population. So it refers to the number of new cases of some condition in a disease or some condition in a population. So, for example, in the incidence gives us information how many there were new cases of a certain disease in a given year in a given population. Yeah, it is important always to understand that these numbers are telling us about the morbidity or incidence in a population at risk. Yeah, so for example, if we're speaking about some gynecological problems, we will be calculating this incidence and prevalence for female population. If we're speaking about cardiovascular pathology, so gynecological problems are calculated only for females because only females are susceptible for gynecological problems. And if we're speaking about cardiovascular diseases, these cardiovascular diseases will be calculated for overall population because regardless of sex or gender, people are susceptible to cardiovascular diseases. So this is the difference. So let's begin with morbidity. One moment. So let's speak about morbidity. So once again, it's the number of present cases in a population in a given time. Otherwise, it's called disease prevalence. It is calculated like as a number of existing cases divided by population at risk. It's very important, population at risk, and multiplied by some coefficient. Usually, the coefficient depends on the number of population. For example, if we're speaking about worldwide prevalence, or it might also depend on the prevalence itself. Usually, we use large numbers. For example, how many there are people for 10,000 of population or 100,000 of population, etc. Depends on which scale you are using to compare the numbers. So let's say if we take the official information about diabetes from World Diabetes Atlas, you will see that it is around 5.8 people per 1,000 population. So almost 6 people per each 1,000 of population worldwide will suffer from diabetes, unfortunately. Also, you can see that there are different ways to present prevalence. For example, using the same source, we can see that if we make some stratification of population, so if we'll take not all the population, but also only people from 20 till their 80s, we'll see that 10.5% of population suffer from diabetes suffer from diabetes. Yeah, so it may be described as number of people per 1,000 population, 100,000 population, or it might be described as percentage as well. Here is the example of incidence calculation. So incidence is the number of new cases, usually calculated for a given time point. Usually we'll calculate it for a year. Incidence is calculated as a number of new cases divided over population at risk, again, multiplied by some coefficient. Mortality, pretty the same, but it will take the number of deaths and divided by population at risk and multiplied by some coefficient. And for example, if we're speaking about diabetes incidence, it will give us number of 5.9 per 1,000 population. I guess it's only the data from 2021. I guess there might be some kind of error. Yes, I will need to check it out. But because usually the incidence and prevalence are not pretty the same. So for disease like diabetes, prevalence should be usually higher than incidence because because people with diabetes can live for a pretty long period of time after the moment of diagnosis. This is why the prevalence is kind of more or less constantly increases, given that people are receiving the proper treatment, and incidence remains more or less the same unless some kind of shifts occur in the population which lead to increase in incidence as well. So we are done with the analytical studies or with observational studies, and then I would like to say a few words about experimental studies. Experimental studies, unlike observational studies, imply that we do some manipulation with the studied population or studied phenomena. Yeah, so we do not, if in analytical studies we didn't choose who will be smoking and who will be not smoking, but in case of experimental studies, we do decide who is going to be exposed and who is not going to be exposed. Of course, it's been regulated by ethical rules, which should be very strictly adhered during the conduction of experimental studies. But this will be the topic for another study of another lecture. But what we should know for now that for conduction of experimental studies, we need to have a study sample. Then we should do the process of randomization. We'll speak about it a bit later. And then we form an exposed cohort and unexposed cohort, and then we observe the number of outcomes in both cohorts, exposed and unexposed. So how can it be working? So let's say that we have an educated guess that drugs from a group of statins can prevent some cardiovascular events, for example, myocardial infarction. Yeah. This guess is educated because we know that statins reduce the level of cholesterol in the blood. And we already know, for example, from cohort studies that cholesterol the elevated level of cholesterol is associated with higher risk of myocardial infarction. Yeah, so reducing cholesterol, we are trying to control the risk of myocardial infarction. So for this purpose, we need to assign some people who will be taking statins for some period of time, which will be meaningful for checking this hypothesis, and check how many people among those will develop myocardial infarction. And there will be some cohort of people who will be treated exactly the same as the exposed cohort, only with the without statins. Yes, so they will be the same, but not treated with statins. And also we will calculate how many of them will develop myocardial infarction and how many of them will not. And so logic is pretty similar to a cohort study, but with the difference that we decide who will be exposed and who will be not. Why do we need this randomization? Randomization is the very important process of the randomized controlled trial. Why? Because in this study sample, we usually try to form the study sample to have participants as similar as possible. Yes, so to have more or less homogeneous population, which will be different only on one parameter. and this parameter is the exposure. Yeah, so we would like this two cohorts be ideally the same, but with one only difference is the exposure. Yeah, so and to make sure that these two cohorts are the same, or to reduce the chance that these cohorts are different, and to leave this chance to be different only to kind of by chance, we introduce this randomization. So roughly it works like throwing a coin. Yes, so if it's one side, the person goes to exposed cohort. If it is another side, the person goes to another cohort. Why is it important? It is important because this makes sure that people are allocated into both groups by chance, not by the willing of the people who conduct this study, but by chance. Why is this important? Because so I would like to pay attention to the definition. So the randomization is the process of assigning of participants randomly to the exposed and unexposed group. If it is not done, randomly, it creates the foundation for a bias. Yeah, for example, if this selection is done by a specialist, for example, by a doctor might have some presumptions who of patients is more likely to develop an outcome and who is not, who is less likely to develop an outcome. And he might be willingly or unwillingly assigning people to exposed or unexposed cohort based on his expectations. And then this will introduce the bias. So bias is the deformation of cohorts, which makes some cohorts more likely to develop an outcome even without the introduction of the exposure. Yeah. So if this presumption is present in this formation of exposed and unexposed cohorts, then we're speaking about bias. Yeah, bias is an error which is explained by some intention or not intention, but still by some systematic process which led to the formation of cohorts. But randomization will try to reduce this inequality, and if inequality still exists, it will be called an error, because okay, it's not okay to have not equal exposed and unexposed cohort, but it occurred by chance and there is nobody to blame. So this will be an error. It just happens. So some random things can happen and we can do nothing with it. We can only to reduce their probability. And a few words about bias. So I've said earlier that if some problem in the study happens, it's possible. But if it was controlled and it just happened, it is an error. Yes, so something can happen by chance, and we just need to be ready for this. But what we are trying to eliminate from the study is a bias. Bias is the systematic deformation of the study design, which may lead to distortion of study results, and which may have, unfortunately, very many roots. Here are some examples of bias. Yeah, for example, this is selection bias. Selection bias is what I've described you. For example, if a doctor who assigns people into studied groups believes that some people are more likely to benefit from a treatment in which he believes, for example, doctors strongly believe the statins are good. And to prove this idea, doctor will, for example, unconsciously, let's believe that unconsciously, will assign people with better prognosis into the group of statins, and it will increase the effect of statins in the end of the study. Yes, so we don't know, we cannot be sure in this case if this group of people was better in outcomes because of the selection bias or because of treatment with statins. This is why selection bias may distort the results pretty strongly. The another one is a confounding bias. Yeah, for example, if we are studying the influence of, let's say, smoking on the liver cirrhosis, yeah, just the rough example. Yeah, so we're trying to establish the association, if there is any connection between smoking and liver cirrhosis, and we found one. For example, let's say that we find one. But in this case, we need to make sure that there is no confounding bias. What confounding is when some causal factor is associated with another one. Smoking, when people smoke, we can assume that people when smoking can be drinking also. And alcohol consumption is associated with the liver cirrhosis. So in this case, alcohol consumption may be a confounder for association between smoking and liver cirrhosis. And there might be also an information bias when, for example, study participants were wrongly informed about the study protocol or study outcomes, or they were interrogated incorrectly about some factors in their past. Yeah, for example, people who developed the outcome may recall some information about the exposure because of personal information. Yeah, for example, if a person develops a cancer, this person will be more likely to recall that there were some episodes in the past which could have led to this episode of cancer. But a person without cancer in present even may be less likely to recall the same episodes in the past, just because this person didn't develop, haven't developed the cancer by the time of interrogation. So this might be an example of information bias. And a few words about clinical epidemiology. Clinical epidemiology is the section of epidemiology which deals with clinical problems. So epidemiology can be working with health or disease issues on different scales, but clinical epidemiology uses and solves the issues at the level of patient. Yeah, so population and patient should be dealt differently. It's used as an aid to clinical decisions for making clinical decisions, and tries to get to the conclusions, to correct conclusions, avoiding some errors and bias and some conclusions that be drawn by chance. So clinical epidemiology tries to eliminate the influence of random factors on making clinical decisions. When speaking about clinical epidemiology, you will frequently see such terms as sensitivity, specificity, predictive value of a positive result, and predictive value of a negative result. So what does it mean in human language? Yeah, so what do you see on the screen is a 2x2 table, which also called contingency table. And in this particular case, it presents the relation between the presence of a disease and presence of a test which aims to confirm this disease. Yeah. So let's say that we have some pool of people. Some of them have disease, some of them don't have disease, and these people were tested using some investigation. And for some people, the result was positive, and for some people, the result was negative. So in case if the people a person have a disease and the result is positive, we call this person as a true positive result, having a true positive result. So there is a disease and result is positive. Test confirms existing disease, true positive. If the disease is absent, but test is still positive, we call this result as a falsely positive. It is positive, but there is no disease. If a person has a disease but test shows negative, we call this result as a falsely negative. Yes, so the disease is present, but test tells us that there is no disease, which as you can understand, pretty dangerous, because there is a disease, but we don't know yet that this disease is present. And there's also a variant when there is no disease and the result is negative. So correct classification. So these classifications are correct. So when there is no disease and the result is negative, and whereas disease and the result is positive, correct classification. And there are situations when classification is not correct, when disease is missed or overdiagnosed. So for this, for quantifying of these things, we use the terms of sensitivity and specificity. Sensitivity is percent of positive results in patient with the disease. So for this purpose, we need to divide this number of people over all people who have a disease. And we also would like to calculate usually the specificity. People without disease among people who do not have a disease at all, including all those people who have falsely positive results. So how does it look like in practice? So let's say that we've investigated 500 people. Among them, there were 35 with the colon cancer, and for 25 of them, result was positive and 10 was negative. For 10 people, it has missed the diagnosis, which is very bad. So we would like to know how reliable, how sure can we be that if a person has a disease, our proposed test will catch this disease. So we take this 25 people and divide it over all people who had colon cancer in our study. So 25 over 35, it will give us 0.71. So 71% with the colon cancer will be caught using this given diagnostic test, which is pretty kind of good. It's better than just random guessing. It's more than 0.5, but still we understand that we would like to have the test with the better sensitivity. We'd like to have the test which will catch as many people with the disease as possible. And also would like to pay attention to people who received negative test. Yeah. So there were people without colon cancer who received negative tests. So healthy people with negative result, it's okay. And there were people without colon cancer, but who received positive result, which is kind of not as bad as at least in my perspective, as having falsely negative test. But still, it might be unpleasant because it's pretty stressful. It will require some further investigation for ruling out the diagnosis. Yeah. So, and we would like to know how sure can we be that if a test is negative, it's really negative. So, yeah, so that there is no false kind of false negativity or false positivity. For this purpose, we take the people with the negative tests, truly negative tests, and divide them by the whole number of people without the disease. So we divide 460 over 465, we get 0.99. So we can be 99% sure that if the test is negative, that there is really no disease in this person. So this is why do we need this parameter sensitivity and specificity. In a clinical practice, you might encounter these terms pretty frequently, especially when you will be working with diagnostic criteria. Yes, so this is a set of criteria which are used to confirm or rule out certain diagnoses. So this is the illustration how this sensitivity and specificity may look like if we turn it into graphical regimen. Yeah. So, for example, why do we need these diagnostic tests? We need them to differentiate between a healthy population or the population without a disease, and to differentiate them from population with a disease. Yeah. So kind of this picture gives you the visual difference that these populations are pretty different, and we are trying to rule out between these two populations using one test. For example, let's say we are speaking about the blood glucose level. Yeah. So we know that there's a population of people with diabetes. We know that there is a healthy population of people. And we would like to differentiate between these two groups of people using the level of blood glucose. Yeah. So how can we apply this information over this picture? So let's say that we take a threshold of 6.0 millimole per liter as a diagnostic threshold for diabetes. So the majority of healthy people will have the blood glucose below this level. There is still small chance that healthy people will occasionally have blood glucose level above 6, but this chance is pretty small. Yeah. But in case of people with diabetes, the level of glucose of 6.0 might be pretty well working, because the majority of people with diabetes will have the blood level of glucose above 6.0, and only small people or small proportion of people with diabetes by chance might have occasionally the blood level of glucose below 6.0. So what does it mean? It is still possible that we will falsely classify a person as having diabetes using blood glucose level, but still after further evaluation, we will clarify that this person is healthy. And there is still some, one moment, please. I assume that the record is being continued. So we can distinguish between So we can distinguish between these two populations using blood glucose level. Yeah, so it's pretty small chance that person with diabetes will have blood glucose less than 6.0. So this is the illustration of why do we need this specificity and sensitivity parameters. And this is the final slide for the presentation. It is about the hierarchy of evidence. So why do we need these different types of studies, and why do we bother with all this pretty complicated stuff? So on the top of this pyramid of or hierarchy of evidence, you can see that there are clinical practice guidelines. Clinical practice guidelines are the documents that mostly doctors are working with. So those are the guidelines written in the most explicit way possible about, and it tells doctors about what should be done with the different patients in different clinical situations. Yeah, for example, if a patient has elevation of blood glucose, please do these investigations, please do these interventions, etc., etc. But to create this body of recommendations, experts who are creating these clinical guidelines have to rely on something. And they rely usually on the studies which were conducted previously. And this is when our types of studies step in. So first of all, we have some ideas about causality of disease or some ideas about natural evolution of diseases. And these hypotheses are formulated or proved using animal and laboratory studies or observational studies or case reports, etc. So these studies do not involve any or very kind of simple design, are not very reliable, and used for the formation of hypotheses. When hypothesis is already there, we can design case control or cohort studies, or if it is possible or necessary, we can conduct randomized controlled trials. By the way, I didn't say it previously, but randomized controlled trials are supposed to be, at the moment, the gold standard for proving or disproving hypotheses in biomedical studies. It doesn't mean that they are always possible or necessary. For example, in some cases, it's impossible to conduct randomized controlled trials. For example, like in case of vaccination. Yeah, for example, you cannot decide who will be vaccinated and who will be not. It's usually unethical. But still, when it's possible, randomized controlled trials should be used because they provide us with the most reliable information about the relation between our exposure and outcome. So then when the hypothesis is there, we can conduct some analytical, or descriptive or experimental studies. After that, when some number of studies has been conducted, the results of the studies can be systematized using meta-analysis or systematic reviews, and which in turn, the whole this body of evidence will be analyzed and taken into account during the formation of clinical practice guidelines. So clinical practice guideline is the top of the pyramid, which cannot be created without this extensive, long, hard groundwork, which starts from the idea formation until the idea proving or disproving. Okay, sorry, not the last slide. This is how this hierarchy of evidence can be presented in the clinical guidelines. In this case, I've presented the example used by European Society of Cardiology. Principally, it will be the same, but the general view can be different. So you can see that there are recommendations which can be so they are usually divided into classes from 1 to 3. So class 1 is when the intervention is useful and beneficial and it should be recommended. Class 2, when there is no strict kind of basis for recommending of some intervention or evaluation, but still it is rather more beneficial than not beneficial. So you can consider this intervention. And there is class 3 recommendation when this intervention is not recommended. And these classes of recommendations are supported by level of evidence. Yes, so level of evidence A, the strongest. The data were proven from randomized controlled trials or meta-analysis, so very well proven idea. Level of evidence B, data derived from a single randomized trial, so one randomized controlled trial, but a single one, or non-randomized studies like cohort studies or case control studies. So still good, but worse than level of evidence A. And level of evidence C, it is consensus opinion which relies on small studies or the opinions of experts. So for example, how can it look like? It can look like, for example, do ECG to patients with the chest pain. Let's say it's just a hypothetical example. Class of recommendation 1, it is absolutely beneficial. So everybody agrees that this class recommendation is beneficial, and level of evidence A. So it has been proven in multiple randomized trials that person with chest pain should be done ECG. So this is how it can look like. Or for example, if you see a person with a chest pain, observe for this person for 2 days to figure out the diagnosis. You can see in all probability if there was some such a recommendation, you will in all probability you will see the class of recommendation 3. Do not do this in any case, and level of evidence A. So everybody is sure that you should not do this in any case. You should not observe a patient with the chest pain for 2 days. You just need to deal with this patient immediately, to prevent myocardial infarction. Yes, this was the final slide. Thank you very much for your attention, and see you on practical lessons. Goodbye.